Good morning, everyone. Welcome to Pulmonary Arterial Hypertension Rounds, uncovering treatment pearls from fellows. And I'm Dr. Jean Elwing. I'm from the University of Cincinnati, and I'm joined by two fantastic fellows. First, Dr. Maura Thornton, who recently completed her training in pulmonary critical care at UNC Chapel Hill and is now doing advanced training in pulmonary hypertension and ILD, as well as her master's in clinical research. And Zhou, who's a third year at the University of Cincinnati in pulmonary critical care and will start an IM Star fellowship program with a focus on education and a master's in learning analytics and AI next year. So we're going to go through a case, and we're going to use it to highlight risk assessment, guideline-directed therapy, treatment, follow-up, and interprofessional care in our teams that care for our patients. So I'm going to present the case, and then I'm going to talk with Christine and Maura about how to evaluate and manage this patient. So this is our patient, Miss A. Fantastic lady, 40 years old. She comes to you with a diagnosis of PAH. She thinks it's idiopathic. She's been short of breath for 8 months. She's now short of breath with routine tasks. She has lower extremity edema, palpitations. She even feels lightheaded after she exerts herself. She's not been to the ER. She has not been to the hospital. She's coming to you for help. So you evaluate, you get your old data, put it all together. So vital signs, blood pressure is 104/66, heart rate is 92. She has 8 to 9 centimeter JVD, and on cardiac exam, just allowed P2. She does have that mild lower extremity edema that she noted, but when you look at her, you don't see any signs of connective tissue disease. But you know she's coming with this diagnosis of pulmonary arterial hypertension, so you want to get her old data. Her echo showed a moderately dilated right ventricle with reduced systolic function. Her TAPSE was only 1.5, and her pressures were estimated at 75, so significantly higher than normal. The physician who evaluated her before you did look for other causes of shortness of breath. They did a PFT, which was normal in terms of the spirometry, but the DLCO was low at 45%. She had a VQ, which did not show any perfusion defects, so no evidence of chronic PE. She did have her heart cath. You looked at it, and you looked at the tracings. And you agree her mean PA pressure was 48, so clearly meeting that definition of greater than 20 for pulmonary hypertension. Her wedge was 8. Her right atrial pressure was 12, so higher than you like it. Her cardiac index was low at 1.9. And when you recalculated her PVR, you agreed it was elevated at 10. She did have a vasoreactive challenge with nitric oxide. It was negative. You did dig in there and find some additional testing. She had an old NT proBNP that was 1,000. Her last walk was her last 6-minute walk was 300 meters. Her creatinine was normal at 0.9, negative HIV, negative ANA, and she did have some other studies looking for other causes of why she might feel so low in terms of her exercise tolerance and her energy, and her ferritin was borderline low. So you wanted to know, what does she do for a living? What is her history? She's a school teacher. She didn't access care from a PH center because she lives an hour away, and now she's made that trek. She has 2 small children, and when you talk to her, you get a sense that she would be very concerned about infusion therapy because of the distance she lives from the center. But she is highly motivated. She wants to know what you recommend and wants to follow that direction. The only medication she's on when she hits your door is some Lasix, 20 milligrams, prescribed by her primary care physician. So with all of that information, she's going to see Maura. And you're going to have to take all of that information and distill it down into something you can use to guide your management. So what steps do you take prior to consideration of PAH therapy, when you're thinking about treatment, how do you evaluate her?
Yeah, so I always start with the risk calculation to guide therapy. That's the way that World Symposium and PH recommends doing it. And I use Reveal 2.0 because it's validated in the American population. And in this case, I look at her functional class, blood pressure. Essentially, what we have listed here, we've got her slide up with her risk score, and she's an intermediate. She's a 7 to an 8. And what that means is that she has an intermediate risk of mortality from PAH in the next 1 year. For Reveal, that's about, I think, a 6.5% mortality risk. If she were low risk, that would be closer to 2% risk of mortality from her PAH. And if she were high risk, that would be, upwards of 25% risk of mortality. So it does make a difference. And this calculator, one of the reasons that I like it is that it's good at distinguishing between, intermediate and high, that there is a really big difference between those. And there's also, 3 times kind of relative risk difference between low and intermediate.
So a very powerful tool to help us understand people like her and their overall risk for that short term, and helping us to guide how aggressive to be, of course. But how do you take that information and explain it to Miss A?
Yeah, so when I talk to patients, I say, we're taking factors about you, like your age, your background, and factors about your disease, your right heart hemodynamics, your symptoms, your functional class, right? What can you do? What are you feeling? How far can you walk? And we put all of those together to learn about how bad is your disease, how well controlled or not well controlled is your disease, and that as I said, gives us a probability of mortality, but it also tells us how aggressive we need to be to get them to that low risk status that is our goal for treatment.
Okay, I think that's really important because, as we stated, she is not really excited about being treated with infusion therapy because, of course, she has read about it, like every patient that comes to see us, and has so many questions and concerns. So, Chris, now she's going to consult with you based on her risk score. What does that risk assessment tell you about the urgency of therapy or treatment?
The Reveal 2.0 score of 7, as Maura was saying, leads to a relatively high mortality risk in that first year, which means that we really should be getting on treatment sooner rather than later. And so this first visit, even though she's really nervous about it, I would probably be trying to spend a lot of time just counseling her through that, because I think it's really important that we get started on therapy now. The types of therapy will obviously be kind of a shared decision-making process with her, but her right heart is under strain, her TAPSE was low, her cardiac index was already low, and then she's already having significant symptoms. She has dizziness with walking, her walk distance is already a little bit low. These things all kind of indicate that she's somebody who is already on the borderline of right heart failure, and needs to get therapy initiated sooner rather than later so that we can prevent her from getting worse.
Very true. And sometimes when you really talk about it in that way, you realize the severity of her illness. You really honed in on her symptoms that she's experiencing and put that together with the risk score. As you said, treatment sooner than later, as soon as we can get it. So can you walk us through the recommended pathway based on the most updated algorithm from the World Symposium?
Yeah, the updated algorithm for the World Symposium, I think, actually simplified it at the initial part. So now we divide, after our initial risk assessment, we go between either high risk or not high risk. So that means that intermediate and low risk both fall into just the not high risk category. So we know that from a prior calculation that she's in this intermediate risk. So that shunts her off to the left of this diagram, then the not high risk. And so we'd be starting a combination of ERA and PDE5 inhibitors. The specific type, if we are able to, we can consider doing a single agent combination therapy, but the initial titration up could just be with separate therapies so that we know we get to the right dosage.
Very good point. There's some options now, even in that not high risk group, of fixed dose combination or loose separate therapies. So we started on medications, and we were able to secure both an ERA and PD5. So that was the appropriate therapy, as you said, Christine, for an intermediate risk IPAH patients. So let's talk about maybe some barriers we might face or some discussions we have in this situation. So I'm going to ask each of you a couple of questions. So Chris, before you wrote that prescription, what type of education did you provide to Miss A about these therapies?
The main ones that I always think of are side effects, as well as the talking about both the effects of the medication as well as the effects of not taking the medication. As we get into a lot of pH therapies, due to their effects on the hemodynamics, if they stop taking therapies for whatever reason, it can have some pretty profound effects, and then it could start getting worse and send them into right heart failure, especially for this type of patient who's already kind of on the borderline, as we said. So a fair amount of time right at the beginning, just being like, hey, we are starting therapies. It's really important for you to stay on it. If you're having issues, please let us know that we're in a partnership with you. We don't want you to just kind of stop taking therapies and go off on your own because we're worried about you, and we'd rather, back down on something or things like that, or work with you, try something different to make sure that you can stay on the therapies that we think that you need to be on. So a lot of upfront talking about how this is a partnership and how we're going to be together for a while, as opposed to telling them, hey, you're on your own, so that they feel like they can trust us to come back if they start feeling significant issues or other things going on.
No, very important, because you definitely want to modify rather than have them discontinue, and you find out a month later when they're really sick.
Absolutely. In terms of just like side effects and like things like that, the ERAs, for example, for she's I'm not entirely sure of the rest of her family situation, but she's technically still within childbearing age. So the effects on pregnancy have to be at least stated up front so that she knows and is aware. And then a number of the typical side effects of just like the headaches and the flushing that you can get, sometimes a little bit of diarrhea, or just other warning symptoms. If you're starting to feel more short of breath with the ERAs, are you developing other issues related to those medications? All those things to be, which things should she be watching out for that suggest that we need to modify therapy, and which things are the ones that unfortunately she might have to live with a little bit and will help her through with other types of medications.
No, very, very, very important. So Maura, when you prescribe, what do you do in terms of counseling on these specialty pharmacies and what the patients need to do to maintain their therapies? Because many times they get very confused, at least in my situation, about the 3 specialty pharmacies that maybe contact them about 3 different medications. So how do you keep them on track?
Yeah, it is really, really challenging. And I think we have the benefit, especially at a PH center, of a multidisciplinary team, right? You have a nurse coordinator. Oftentimes you may have a pharmacist in addition to the physician, and working together to get patients the medicines that they need is so important. A lot of times we might get, 30 days approved from one pharmacy, but then the rest of the supply for the year is going to come from a different pharmacy. And it's confusing. And it's like Christine said, you really need to help people feel comfortable reaching out and saying, I'm running out of medicine, and I don't know when my medicine is next going to arrive. And, please, can you help me? Or, it's not arriving for 3 days. Can you send me a short supply? Whatever it is, because these logistics of these medicines are challenging, and making sure that people feel supported and know how to navigate, where they're getting their medicine and when they're getting their medicine is really critical. And the other thing is just remembering to take your medicines. Lots of people are going from not having disease, not having been on medicine, to suddenly needing to take a medicine maybe 3 times a day, and that transition can be really challenging. And so making sure that people know, set a reminder on your phone, or that you're asking people, well, what's going to help you remember to take this medicine on time? And to be honest, how often are you missing doses? Is this something where you're not able to take this medicine in the middle of the day because, you're a nurse and you're working and you're, away from your purse dealing with a patient, and you can't get that medicine in? Do we need to switch formulations to something that's a 24-hour med that doesn't need to be taken multiple times a day?
Right.
And we have the resources to advocate for that. And so it's important that we elicit those patient factors and know, what are these barriers to getting medicines in.
Absolutely, because nothing works if you don't get it and you don't take it. And that's something that is hard for us because we are trained. We do our differential diagnosis, we write our prescriptions, and magically the things happen for patients. And that's, of course, not how the real world works for many patients. Insurance interruptions, moving to a new PH center, all can really disrupt their care. So
Yeah.
I think Christine mentioned something earlier about a combination pill that might be helpful for some patients. Can you tell us a little bit more about that?
So this is Opsynvi is a combination of tadalafil and macitentan, so an ERA and a PDE5 inhibitor, and it's a one time a day, one pill and done, and it does work very well. I will say, it is, because it's a newer formulation, it's one that's often trickier to get with manufacturer assistance or grant money. And so it's not one that I prescribe as often, because it's more common that I'll give people 2 separate pills, and then I can get assistance for that. And I really want people to know, right? We can get you grant money for medicines. We can get you manufacturer assistance, because cost is such an important factor for people. But yes, that is a great option for when adherence and taking medicines multiple times a day is a real challenge.
Yes. So I think knowing all the options and having the resources like a pharmacist or a social worker or your specialty pharmacy to assist you through those challenges financially for patients. Now, when I started talking about Miss A, I mentioned that she was hesitant about prostacyclins. So say she was in that high-risk status when you met her, or she's getting worse. Chris, when you're thinking about prostacyclins, how does that change the discussion you have? And how would you help her even consider that as an option? Christine?
Sorry. I think that I mentioned previously, so much of this is really built on developing that relationship really upfront with the patient and making sure that they understand this is a partnership. And I think that gets even more important as you start getting into the infusion therapies and prostacyclins, because there's so much to them. And those logistics that Maura was talking about earlier, they just kind of explode when you start talking about these other therapies. I find that by focusing a lot on the symptoms that they kind of already have and saying, hey, like these symptoms they're already affecting your life so much. And if we keep letting them go, they will continue to affect your life or your mortality in ways that is unacceptable, right? To allow happen. And so while you are really nervous about them, and while I know this is a lot, you should know that we have an entire team here that's really set up to help you succeed with these medications. Oftentimes it takes a while for all of those medications to get through insurance anyways. And then they also need like a line placed, for example, for infusions, if that's the type of infusion they want, or they need to learn how to use the subcutaneous pumps and like things like that. So that process ends up being a fairly long process, longer than just taking the pills. And that entire process ends up just being an opportunity for the entire team to get to know the patient, for them to get to know us, and for us to develop that kind of relationship where they feel a lot more comfortable embarking on this really massive step in their therapy, because now they've like had this entire time where they are getting educated and where we are getting educated about them, and to form that partnership that's so necessary for their care.
No, that's so powerful for patients to go to spaces they're really kind of scared of, right? And if all of us are sending the same message to them and telling them, we will never ask you to do something we don't think you can do or can't afford. We wouldn't ask you to do that. And we're telling you that we think that this is the best option for you. And that's really comforting to patients. And I think if we all come together when we care for patients, inpatient, outpatient, in the ER, with that same message, it really helps them. So, Maura, I'm going to ask you a hard question. In addition to that, how do you create that bond with the patient and create space so patients can tell you what they're scared of and what their barriers are?
Yeah, absolutely. I mean, I think Christine already said, you want people to feel that there's a partnership. You want them to feel comfortable. And so I really try to emphasize, I need you to feel comfortable coming to me when you have a problem with these medicines, when you're not tolerating side effects, when you're not comfortable with, the plan of care, or you don't understand, because we are working together. And these changes, if you don't come to me, put you at risk. And that's something that, nobody wants. Everybody wants you as the patient to get better and to improve. Yeah.
Of course. Yes. So we started her on the combination ERA PD5, and she is on her way. She's back home. She's taking the medication. She is adherent. Christine, when do you want her to come back, and what kind of tests do you want to do at her follow-up?
Typically, I'd like her to come back around 3 to 4 months. If things are going wrong, maybe a little bit sooner than that, but typically 3 or 4 months. That should give her enough time both to get the medications as well as to have been on it for hopefully long enough that she can kind of give us a little bit more information about how she's handling it. The certain types of tests, so as we repeat our risk assessments, we want to make sure we get the tests that allow us to understand where her risk now is. So another 6-minute walk test, some laboratory tests, for example, do we need to check on our kidney function again? Do we need to check on our volume status with an NT-pro or BNP? And then we may want to consider also getting a repeat echocardiogram. If things have like really drastically changed, usually for the worse, at some point we may even consider a pretty soon right heart cath, but I don't find that people typically need that at 3 months. So usually just the functional markers as well as some laboratory exams.
Awesome. And that's exactly what I would do also. Maura, do you agree?
I do. And I've, especially starting out in this last year, I think I was bringing people back a little sooner. And I do think it really does take, 3 months. Just give it time for things to settle out, and for those improvements to come through. So I think sometimes it's tempting to try to reassess risk almost too early, and it is worth just giving it time and letting people improve.
Mm-hmm. Yeah, these medicines don't work overnight.
Yeah.
So I'm going to give you some hypothetical follow-up information. So she's still functional class 3. Her walk distance is 300 meters. Her NT-proBNP is 1,000. She has reduced RV function on her echo, and you did a right heart cath because she doesn't feel well. PVR remains high, cardiac index remains in that low level. So what are you going to do now? Are you going to use that information to risk assess again, and how would you counsel her?
Yeah, I do risk assess again. And again, I'm a Reveal 2.0 girly, so I use the Reveal 2.0 light, but Compara is just as good. And she's still intermediate risk at this level. So, on the one hand, she's perhaps having more symptoms, not feeling as well, and that's important. But overall, she's really sort of stable. She's not changed from that initial risk assessment. And what that tells me is we need more therapies. We need to add on medicines to reach that goal of low risk.
Okay, I agree. We're definitely not reaching the goal of low risk status. So Christine, you're going to see her back now. Based on her follow-up, how would you decide what changes to make, and what algorithm or guidelines are you going to look at?
So going back to the new guidelines for the World Symposium, the follow-up risk assessment now splits the not high-risk category, but more into low-risk, intermediate, and the intermediate high. So following that, she falls kind of more into this intermediate high-risk area. And so we're talking about adding on therapies. So we already have her on the ERA and the PDE. And so now we're talking about either prostacyclin, so either the oral or the parenteral prostacyclins. And then additionally, the newer activin signaling inhibitor, so sotatercept, is now available as well. For somebody like her, since she was really concerned about the infusions in the first place, and I'm assuming she still lives an hour away, which will obviously be challenging for infusion therapies, then maybe a consideration for the oral, like selexipag for prostacyclin, in addition, plus or minus sotatercept, so which is a every 3-week injectable. might be a good way to move forward so that we can actually get her up to quadruple therapy with avoiding infusions entirely.
Mhm. So definitely, we have a lot of options for therapy, and we have to do this in a way that works for her. If I told you, she says, Dr. Zhou, I can't take this anymore. I want to get better. I can't go to the games that my kids want to play. I'm on the sidelines for things they're doing at school. I'm getting behind in my work. I need something stronger. If she tells you that and she's like, I'm open to anything, what approach would you take then?
I think at that point, we're really talking about infusion therapies. It's by far got the strongest evidence. It's the most potent. It'll work the fastest out of all of those. And then typically, we are using a lot of subcutaneous treprostinil or Remodulin to avoid a little bit of some of the scariness that comes with Velitri or the epoprostenol. And that also, the longer half-life of that infusion should give her enough time that even with an hour away, she'll have enough time to come back to the center if something were to go wrong with her pump or with the infusion in some way, shape, or form. But I think if at that point, if she's like, nope, I really need something that works faster, then I would match her level of enthusiasm for therapy and just be aggressive upfront with it and go for one of the infusion therapies.
Yes. And I think that's where the shared decision making really comes into play, because we can recommend anything, but if that individual patient isn't receptive, it doesn't impact her in any positive way because we're not going to proceed. So I think that really clear, open dialogue is so essential. So Maura, how do you approach this situation? Because she's intermediate high risk. She's a young person. She has a lot of life to live. Would you push her towards infusion therapy or sooner sotatercept? How would you approach that in your experience so far with your role in pulmonary hypertension?
Yeah, I think the first thing that I start with is, what are the worries that you have about this medicine? How can we help this, IV medicine or sub-Q medicine fit into your life better? What are the things that alarm you? Some people, they have really young kids. They're worried about kids pulling on lines. They're worried about infection risk. Or they, with the subcutaneous pump, they just have a lot of problems with pain. They don't have a lot of body fat. They're not going to absorb it very well. Like there are good reasons to move away from those and towards an earlier sotatercept. But I think that, like Christine said, the evidence that we have for the prostacyclin analogs is really good evidence. And so that is my first choice for patients who are in this situation. We have, I think, Hyperion for sotatercept that fits patients, first year of diagnosis, PAH, and still intermediate risk functional class 2 or 3. That is a reasonable time to use sotatercept, but it can also be hard to get it approved. And I think that's, again, speaks to some of the strong data that we have for the prostacyclin analogs. So I talk to people about how it could fit into their life, what concerns they have, how we can meet those concerns, especially living an hour away, having difficulty with getting medicine delivered. What do they do if there's a problem with the line? Go to your closest emergency room. Obviously, don't drive to the university or PH center. But I do think that sotatercept can be a good option here as well. One of the things that catches me about her case is that she has a low ferritin. And so I also think about, what are the other ways that we can optimize her disease and her symptoms, right? If you have low hemoglobin or low iron, we know just from general heart failure that that's going to make your symptoms worse, and that we can help those symptoms and help your oxygen carrying capacity by, giving iron infusions, even if hemoglobin is still normal.
Very important. Seeing the patient globally, optimizing everything we can. And as you both beautifully described, how everybody's part of this team. You've learned so much during your fellowship and your training. It's actually incredible. So much different than it would have been 10 years ago. So I really want to thank you both for this wonderful discussion. It really highlights how complicated patients are with pulmonary hypertension, how we need to risk assess, and then implement treatment based on that risk with the patient at the core of the decision making. And then we can't just give it up and let it ride over 6 to 12 months. We have to come back, look at the scores, reassess, are we getting to low risk or not, adjust treatment if we need to, and make the most impact we can on this individual with our current therapies. So I just want to thank the audience for joining us. We so enjoyed being able to reach out to you with this patient case, and we hope you enjoyed this educational activity. Please scan the QR code, and we hope to get your feedback and have you receive educational credit for this educational activity. So thank you.